Welcome. So this week and next week, we're going to be doing evidence-based practice colloquiums. This is the clinical methods course for the second year SLPs. There are 6 groups, and so there'll be 3 groups today and 3 groups next week. This is part of the grade. The presentation is part of what they're doing for a grade. So they're going to talk to you about what the evidence-based practice process is, but it's considered actually a summative assessment of a combination of the academic work as well as research and clinical and how you put it all together to figure out what you're going to do in therapy. So each group worked as a team, and they're going to give you different perspectives. They each have a separate case history, and they're going to talk to you about the process and how they manage the process. The forms that you have in front of you are evaluation forms. We use these evaluation forms during our clinical practical presentation practices. And so I wanted everyone to get an idea that it's not just content, but it's also presentation. And so we worked a lot on how do you give a presentation? What sorts of things go into a presentation? And so it was a great exercise for everybody because everybody in the group was really vocal, really verbal, and gave a lot of good feedback to other groups. What was the weakness? What didn't work so well? What worked better? So now we're asking you to do the same thing using the same form that we did. Before you all leave, if you would just kind of leave those forms at the end, and I'll sort them out through groups. Each group is going to give you their name. So you've got three blank papers today. So write down the name of their group at the top. I'm going to write them. They're all going to see these results. So we appreciate it. Thank you.
All right. Welcome, everybody. We are the EBPeeps, so that's what goes on top of your forms there. I'm Colleen.
I'm Lindsay.
I'm Kristen.
And I'm Stephanie.
And today we're going to be presenting on a case study that we picked from a majority of case studies. We are presenting on piecing the puzzle together, a strategy of pragmatics and comorbid ASD and ADHD. Now in front of you, you should have a little piece of paper. You can use this throughout our presentation to refer back to some keywords that we are going to be throwing in and out of our presentation.
So I know that a lot of the first year SLP students have heard us second years talking about EBP this entire semester in the clinic, and I'm sure you're sick of it already. But I can almost guarantee that about 97% of you here have no idea what this project is actually for. So I'm going to explain that a little bit. This project was really designed to be a process and get us thinking about how do we go through the steps of creating a clinical question, how do we look at different areas of research, and then how do we use that research to formulate an answer to that question. And that's how this project was designed. So over here, I'm going to step in front, we have a little model that shows the entire EBP process. So at the top, we have our best research evidence, which is what you're going to be looking at. Anytime you have a clinical question, this is what you are going to want to look for when you do your research. You have your patient values, which is really the driving force behind developing your question. You always want to have that in mind because that's going to be what your research focuses on. Then you have your clinical expertise down here at the bottom. And all of these come together in order to formulate the best answer possible and apply it to your question. So when we started off, we had a case history that we chose, and we looked through it to gather as much information as possible about our client. And from that information that we had, we developed a Pico question that applied to that client. And we took into consideration his own values, what he wanted to improve on, and developed what we wanted to base our research on. So then we looked at a lot of various databases, trying to gather as much evidence-based research as possible to help us then integrate those findings with our patients' values and our own clinical expertise. Then combining all that together, we created a therapy plan that was appropriate and would be the best approach for the client.
For our case study, we chose NH. NH is a 20-year-old male. He was diagnosed with attention deficit hyperactivity disorder, autism spectrum disorder, and Tourette's, and later on at age 13 he was diagnosed with anxiety and depression. He was given the WISC-3, which is the Wechsler Intelligence Scale for Children, where he scored above average intelligence. He was also scored with the Vinland Adaptive Behavior Scale, which showed he had deficits of daily living and difficulty with motor skills and social skills. He currently attends a specialized high school for individuals with learning disabilities. He has two types of goals. He has his IEP goals and his transitional goals, which he formulated himself. His IEP goals focus primarily on behavior management, language, and independent living, and his transitional goals focus on obtaining a part-time job and increasing his relationships with individuals in the community and his peers. He currently has a job in a mailroom 1 time a week with a job coach, but he has difficulty due to the loud noise and coping with that. So some of his primary goals that we wanted to focus on throughout were increasing his pragmatic skills to help him obtain the part-time job and to increase his relationships.
So, based on everything that we learned from the case study, we created a Pico question. And that's also listed on the little form that we gave you. So, if you ever get confused because it is rather lengthy, our Pico question was for adults with comorbid ASD and ADHD. Does a video-based modeling approach to therapy work better than a score skills approach to therapy in terms of social and pragmatic therapy?
Okay, so I know that was quite lengthy. I'm going to break it down into the Pico parts. The P is for population, and for our client, we're looking at adults with ASD and ADHD. The I is for intervention, and we are focusing on social or pragmatic therapy. The C is for comparison, and we are comparing 2 different therapy approaches, a video modeling approach and a score skills strategy. And we'll discuss those in further detail in the next slide. The O is for outcome, and for our client, the ideal outcome would be improved social skills and relationships. At the bottom of the slide, you'll see some keywords we use to search different databases to find studies that would hopefully help us answer this question.
Okay, so taking a look at this slide, like Lindsay said, the approaches that we took a look at for our Pico question had to deal with video modeling for a score skill strategy. So just to give you guys a little bit of an example of what these are, video modeling, which we'll show in the video afterwards, is basically an individual looking at a video happening and then performing a task from that video. A score skill strategy is more or less like a group setting where the individual would be sitting there and would complete a task and then he would get feedback from his peers. So Stephanie's going to play this video, and this is an example of video modeling. This is something that our client in H could sit in a therapy session with his clinician and work on the appropriate and inappropriate greetings and behaviors that he should be performing.
Smiling and saying hi, hello, or how are you?
Oh, hi, Kristen. Hey, Steph. How are you? Good. How are you? Great. Thanks. Bye.
And if you run into someone that you know or friends, you want to acknowledge that you know them and not ignore them, as you will see in the following example.
Hi, Kristen. How are you?
When you meet someone for the first time, you want to introduce yourself, make eye contact, offer your hand for a handshake, and ask their name in return.
Hi, my name's Stephanie. What's your name? Kristen. Nice to meet you. How are you doing?
When you're meeting someone for the first time, it is inappropriate to not make eye contact, not offer your hand in return for a handshake, and to disregard any questions that are asked.
Hi, my name's Stephanie. What's your name? Hi. How are you doing today?
So again, this is something that as a clinician we could work on with our client and each playing this video, and we could even stop it at each intermission of the appropriate greeting, the inappropriate greeting. At the beginning there was bullet points that gave our client the ability to think about what he was going to look for in the video so he knew in advance. And then at the end you could talk with them. about what had happened, what's something that he could implement in the workplace, is this something that he would like to do, or is this something that he would like to modify a little bit? Now, if we were to do this with a score skill strategy, you could implement this video into the group setting and have the entire group watch the video and give their feedback as well.
So this slide just shows the wonderful evidence-based pyramid. And this is a really great model that I'm sure everyone is going to encounter throughout their entire time here. But this really outlines the different levels of evidence that are available to you in your research. So those at the top, these types of evidence-based research have higher rankings, and then those at the bottom have lower rankings. And each article that we gathered information on was then scored according to the evidence-based practice pyramid.
In terms of our research, most of the studies fell under randomized controlled trials, but we also looked at some systematic reviews and a multiple baseline study, which Colleen will discuss next.
Okay, like Lindsay said, we did find multiple randomized control studies. One article that we rated a little bit higher was a multiple baselines. So to explain the rating process a little bit more, the scale was from a 7 to a 1. A 7 is an excellent article. You were able to find what exactly it was, whether it was a multiple baselines trial or a randomized control trial. We were able to learn about the participants, whether they were blinded or not, what kind of atmosphere they were in, their setting, and you were able to pull out all of those pieces. One thing that we did notice as a group, though, was with our research, we found a lot of systematic reviews. And with the guidelines that we were given to rate articles, the systematic reviews that we found did not correspond to those same rating guidelines. So we were unable to rate those systematic reviews the same way that we have rated our randomized control studies and our multiple baselines. But going off of that, we were able to find 3 different randomized control studies that were rated as excellent or good. Good is within that 6 to 5 range. Poor is within the 4 to 1 range. So going off of that a little bit more, our first randomized control trial that we found, we rated as a 6, and this dealt with a meta-analysis of individuals who had ADHD. Next, we found a randomized control trial that we again rated as a 6, and this focused on high-functioning adults with ASD and the social skills training. So that portrayed to NH's workplace environment that he wanted to go towards after his school training. Next, there was a randomized control trial rated as a 5, and this was pertaining to individuals with autism and the use of video modeling. So we were able to kind of pull in that video modeling aspect as well from our Pico question. And finally, the multiple baseline study that we found, we rated as a 4, which on our guidelines was more rated as poor, but we were able to pull information from this study that we found pertinent to our client. Therefore, we decided to go ahead and throw it up here on this table and relate some of our overall findings to it. This study focused on video modeling with individuals with Asperger's syndrome, which is a part of the autism spectrum disorders. So looking through all of our articles, it was difficult for us to take a look at our Pico question and find articles based on comorbid ASD and ADHD and studies that qualified for both using video modeling and the score skill strategy at the same time. So as a group, and talking with Mrs. Taylor a little bit, we decided that we would stick it out with our question, but we would modify it a little bit more and start looking at articles that dealt with just ASD and video modeling, or just ADHD and video modeling, or vice versa, and flip it and do just ASD with a score skill strategy or ADHD with a score skill strategy, and then collaborate all of our findings together.
So when looking at our clients' areas of deficits for pragmatics, we wanted to see if video modeling would be a beneficial technique to take in therapy to help improve these skills. After further research, we found that Video modeling is effective for social skills, functional skills, and behavior management, which all actually relate back to AH's behaviors. Then we have the question of, is video modeling versus video self-modeling, is one more effective than the other? Video modeling is when the client views somebody else completing a given task, and video self-modeling is when the client would videotape himself performing a given task and then watch it later on. We found out that video modeling and video self-modeling were both equally effective.
Another area of research we looked at was video modeling in the workplace. And the study that we focused on was looking at the effectiveness of video modeling when acquiring a new work-related skill or task. And the outcomes of this study showed that there was an increase in accuracy, maintenance, and independence in a work-related task using video modeling. And it also gave the client the ability to review the model if more support was needed to acquire that task. And we can relate these findings directly to our client because one of his goals is to not only have a job, but to increase his independence and relationships in that setting.
So, like Colleen mentioned earlier, we did come up with a little bit of trouble initially starting with our Pico question. And when we went up to Mrs. Taylor to ask her about this, maybe potentially changing our question, she said, no, you can't do that. Because in a real setting, you can't change your client and you can't change your question. So we had to stick with our Pico question. And the part of the question that I really focused on in looking for research was the score skill strategy approach, which we actually found on Passion. So we thought, this is going to be awesome. We're going to get a whole lot of information on it. That was not the case. What we found was that there really isn't any research that's been done that specifically uses a score skills strategy approach. But much of the research uses a similar program that has the same core values and the same setup, and that's known as the PEERS program. And PEERS stands for the Program of the Education and Enrichment of Relational Skills. So one of the studies that I looked at that was pretty high ranked, the researchers had a large group of adults with ASD, and they applied the PEERS program to their groups to see how effective they were in improving their social skills and relational skills. What they found was that in the area of social skills, there was overall improvement for each of the groups. But they also found that there was improvements in specific areas, which included social responsiveness, increased empathy for others. There was also a self-reported decreased amount of loneliness from each of the participations, and there was also an increased frequency of invites to social gatherings, which is something that our client is really wanting to improve. So this showed that the SCORE skills or the PEERS program, the social group therapy, really does make a difference.
As we were going through this whole process and learning that it's kind of difficult to find articles that dealt with comorbid ASD and ADHD, plus the social skills strategy and video modeling are the same, we decided as a group to meet with Dr. Montgomery, who led us in a different direction. The direction that he led us in was looking up articles that dealt with cognitive behavioral therapy. And now what this is it takes the individual themselves and pulls out the key components of the disorder that they have. So for our client and H having both comorbid ASD and ADHD, we were able to pull out some of these specific skills that he could work on within therapy using this cognitive behavioral therapy approach. Some of these skills are things like social cues, recognizing if someone wants to talk to you, or being able to initiate a conversation with someone and having the ability to do that and knowing what is appropriate and what is inappropriate. Looking at theory of mind with our client, knowing that other individuals might have a different perspective on things, or knowing that someone else is sad and having to feel that empathy for them, even though you're not feeling sad yourself. You might have gotten a brand new job or something and you're happy about that, but someone else is sad, so you have to correlate with that. Our client could also work on some attentional skills, especially within the workplace, if he has specific duties that he's wanting to perform, that he needs to perform, he needs to demonstrate that attention to be able to complete his task and complete the entire task, not just bits and parts of it. Our client could also work on some behavioral and cognition therapy as well, and this ties more to his ADHD aspect of knowing what kind of behaviors are going to be appropriate within the workplace, whether if he sits there and bounces his knee within the workplace, is that appropriate? Whether he's like working an office job, or is that inappropriate? He needs to sit there and be still and be able to avert all of his attention and behavior to what is happening.
So that was a lot of information that we gathered. And what we had to do next was we had to gather all of that information, sort through it, and combine it into a system that would work for our client. This took a little bit of time, but going back to the wonderful model of our circles that we used earlier in our presentation, now that we have all of our information, we were able to fill in the different sections of our model to create the entirety of the evidence-based process. So, in the farthest circle, we have NH's, thank you. We have NH's specific goals, and his goals, his own personal values. We wanted to keep that in mind throughout this entire process. At the top, we have, thank you, we have each specific area that we looked at in our research. So we have the different types of approaches that we wanted to look at, and whether or not one is more beneficial than the other. In this last circle, we have our own clinical expertise. And like I said earlier, all of this combined allowed us to form an appropriate answer. So what we found was that both video modeling and a social skills group therapy approach work very well independently for this population. But we decided that the best approach for NH would be to combine the two into one therapy.
So for our intervention, we would first begin by having NH watch a video model of a given task. We chose video modeling instead of video self-modeling due to his limited proactiveness. After viewing the video of the given task, we would then have a discussion on the inappropriate and appropriate behaviors in the video. Then we would have him integrate this into a score skills strategy by having him work with a group of other individuals who are focusing on pragmatic skills as well. He could be the one performing for the other individuals and receiving the feedback, or he could be providing the feedback to the other individuals. Either way, this would provide him with valuable feedback and be able to assist in improvement of these skills. After this, we would like to implement it into the community or workplace and hopefully exceed that generalization from therapy.
So overall limitations and future research. The majority of our studies that we found that were related to our Pico question had child or young adolescent participants, and our client is an adult. So we did consider that one limitation, and we had to use those findings and apply them to our client. Another limitation that Colleen mentioned earlier was finding studies with participants with comorbid ASD and ADHD. So again, we researched both those avenues separately and combined findings. And lastly, like Kristen mentioned, we had a hard time finding research with the score skills strategy approach. So we also consider this a limitation because it was a part of our Pico question. Not only were these limitations, but these are all things we would like to see implemented in future research in order to continue developing therapy for adults with comorbid ASD and ADHD.
And listed here is all of our resources and references that we use throughout this entire process. And we'd like to give a special thanks to Mrs. Taylor and Dr. Montgomery. They helped us a lot throughout our process at various portions. We're the EBPeeps.
Any questions at all?
Thank you.
Oh, wait.
What was the easiest and what was the hardest thing about this whole exercise?
I would say the easiest was going through the case history. I mean, it was all laid out for us.
The hardest was going through all the articles and deciding what was appropriate for our client. And since we did have so many limitations based on our case history, that was also another challenge.
I'd say one of the other biggest challenges that we came across was the ADHD and like the ASD and having to integrate the findings from the various articles since we couldn't find anything comorbid related.
I think once we had all of our information though, it was pretty easy to put it all together, come up with our answer, and then put it into a presentation though.
And a lot of the time too, we used our own clinical expertise of what we've seen in the clinic and trying to tie it into like, okay, this is in a child, how could we portray it into an adult instead? And what kind of therapy approaches that we would use specifically. Yes.
Thank you very much for your presentation. I just wondered, just based also on your clinical opinion as well as what you found, to what extent do you think that the ADHD diagnosis is really significant in what you would or wouldn't do for somebody who's wanting to go as autism?
I think it probably depends on the severity of the ADHD and how you approach your therapy in the session. If he is a person who just really can't sit still and has a lot of trouble focusing, then I think we would have to modify a little bit how we would use our different approaches and apply it to him. We would probably have to get a little creative on, okay, how are we going to make sure that he's paying attention to what he needs to pay attention to? How is he taking away the right information? But if it's not quite as severe, I don't think it would be as big of an issue. I don't think it would play as big a role as the ASD would.
And going off what Kristen said, one of the articles that I had found split up the social skills of an individual with ASD and an individual with ADHD. And they found that even if the individual with just ADHD was medicated or not, the cognitive behavioral therapy approach that they used was midline. They didn't find very positive effects of it, but they didn't find very negative. But using our clinical expertise and tying the two together, we were able to find that focusing on all of the specific skills, the emotion recognition, the social cues, tying it into our client, that he would greatly benefit from it.
Anyone else?
Thank you.
Thank you.